Hello guys, pleasure to be here again. I'm Dr. Hans, I'm the medical director in repromed, and I'm here with John Campbell. He's the deputy lab manager in our clinic, and we wanted to have a chat with you about what PGT is, what is this technique for, how does it work, and why is it useful. Now it also has some limitations that I'm going to talk about, but to understand the different types of PGT that we can perform, I want to explain the differences between a gene and a chromosome. Okay, and this is key to understand the different types of PGT that we have in the lab. So, what is a chromosome? A chromosome is a bundle of genes. Okay, so if I compared John's gene pool to a library, John's library would have 46 bookshelves. Okay, each of these bookshelves has genes. Now, John has one of those bookshelves in the form of an X, the other bookshelf in the form of a Y. That's why he's a boy, okay? If John was a girl, he would have two X's instead of an X and a Y. And that second X would make him a girl, okay? So those are the chromosomes. Now, as I said before, each of these bookshelves has books, and each book has pages. Each of those pages would be one of your genes, okay? So, when we're talking about doing PGT-A, which is by far the most common technique we use in the labs, we're talking about counting the number of these bookshelves in each chromosome, in each embryo. How many chromosomes does this embryo have? Now, when we're talking to couples, like for example, if they're carriers of cystic fibrosis, and that is a genetic disease, then we would not do PGT-A, we would do PGT-M. So PGT-M is looking for a mutation in a gene. When we're doing PGT-A, we cannot see those mutations. We only see the chromosomes, we only see the bookshelves. Now there's a third time, even less common, form of PGT, which is PGT-SR, which would be, for example, if one of John's chromosomes, one of John's bookshelves, was missing a part of that bookshelf. Or maybe that small part of John's chromosome or bookshelf goes and attaches to another chromosome. Those are called structural rearrangements. These can cause miscarriages, these can cause health issues in the baby, and in couples that are carriers or have these rearrangements, those can be looked for in the embryos so that we don't transfer an embryo that is affected by this structural rearrangement. So those are the three types of PGT, which means Preimplantation Genetic Testing. We've spoken a few times about how with women's age the quality of the eggs drops, and what we always talk about is not really the quality of all the eggs dropping, it is the ratio of good to bad eggs that a woman could ovulate or that we could obtain through IVF. Now, a lot of these eggs that we obtain are chromosomically, remember, bookshelves, chromosomically abnormal, meaning they either have too many chromosomes or too little chromosomes. So, for example, if I ovulate an egg, imagine I could, that instead of having 23 chromosomes like all eggs should have, has 24 chromosomes. Now, John fertilizes my egg with his sperm, and his sperm has 23 chromosomes. So now, this embryo that has been formed will have 47 chromosomes. That is a chromosomically abnormal embryo, which we called aneuploid. Aneuploid embryos, the vast majority of them will not implant. The very few that do implant will miscarry. And yes, very rarely some situations can happen where this extra chromosome is, for example, chromosome 21, and we end up with a baby with Down syndrome. And this is why we say that these three conditions increase with female age. Either difficulties to get pregnant, 2, an increase in miscarriage, and 3, an increased risk in Down syndrome. So to explain a bit how PGT-A behaves, I got checkers pieces on the table. When John looks at an embryo in the lab, he doesn't really know how many chromosomes this embryo has. And he has to rely on the laws of probabilities according to the female age. So for example, if we stimulate the ovaries on a girl, that's 35. I know that 50% of these embryos will be abnormal. I just do not know which ones they are. John doesn't either. No matter how pretty an embryo is, and the correlation between how pretty an embryo is and the chromosomes it has is very poor. So we need to choose. Okay? So we study the embryos. So John, how would you study these embryos?
Firstly, what we'll do is we'll be obviously culturing the embryos. That'll be through any of the incubators or a time lapse. We would be grading them, so this would be throughout the kind of day 1 to day 6. The main thing we do though is on day 4 we'll perform what is called hatching. So the embryo is surrounded by what we call the zona pellucida. You might hear us saying the zona if we're ever calling you. We'll make a small hatch on these. It's basically making a hole in the zona to basically encourage the embryo to start hatching out. The part that we biopsy is called the defectoderm. This bit eventually will form part of the placenta. As I said, this bit we biopsy off. So any embryo that's good enough quality on day 5 that this area is hatching out from, we will perform the biopsy. All remaining embryos will be left until day 6. But when we're performing the biopsy, we use kind of a high-powered microscope, and we'll look through and we will basically extract around 4 to 5 cells of this defectoderm. The cells then are tubed and they'll be sent to the genetics lab. The embryo itself is frozen on site here in our cryo storage area. Then the rest will be left till day 6. Any embryos then that are suitable will be biopsied on day 6, and same as again, we will hatch out and try to take part of this defectoderm cell. There can be difficulties with it, basically where the embryo can hatch out from, but we'll be observing this, going through it. The remaining embryos that don't make it to for biopsy on day 5 or day 6 normally will be insufficient quality to freeze, so these will be discarded. The tubes then, as I said, the genetic material will be sent to the genetics lab. It can take around a few weeks to get them back. Once they're back, we can compare those genetic results to the embryos we've frozen. If we get any that come back genetically normal, so euploid is the correct term, these will be transferred back, and if there's any surplus, they can be used in the future. Any embryo that will come back with aneuploid is generally abnormal, these will be kept up to the patient's kind of discretion if they want to keep them or discard them.
And John, we take 4 to 5 cells, you said, and these embryos can have anywhere from 50 to 400 cells,
yeah.
Right? So is that cellular mass that you're taking out of these embryos relevant? Does that affect this embryo in a negative way?
No, there's been studies showing that the embryos, like the part of the spectrum we take, can rejuvenate, and it isn't damaging. As I said, it is part that forms the placenta and kind of helps the embryo grow. But the part we try to stay away from is what we call the inner cell mass. That bit we do not touch. That'll eventually form the fetus. So this part we're taking isn't damaging to the embryo in the future. There's been studies to see has there been any effect with it.
And let's say, for example, a couple has frozen embryos, and then they want to study the genetics, the chromosomes of these embryos. Can these embryos be thawed, biopsied, and refrozen?
Yeah. We'll just carry out a normal thaw out the embryos. We'll give them a few hours to see them develop. We need them to kind of get back to that stage they're at a blastocyst. I may not mention before that all embryos will be at that blastocyst stage when we perform the biopsy, so we can clearly see the defectoderm and the inner cell mass. We'll give them a few hours, then we'll go and try to attempt to biopsy them, and it'll be the exact same procedure. We'll biopsy these embryos, freeze them, wait for the results to get back, and if any come back genetically normal euploid, we'll thaw these out.
Yes, what we were saying is this test is proving to be a very interesting option for patients, but let's be very clear. What I said before, that the vast majority of abnormal embryos will not implant, the very few that do implant miscarry, very little will end up in a baby with abnormalities. Please don't take this like I'm minimizing the heartbreaking difficulties couples go through with a miscarriage, because we have studies showing that a miscarriage can be comparable to the loss of a child. It is very, very, very difficult to go through. But the message is still that the vast majority of these embryos will just not end up in a viable pregnancy with a baby with problems. So, for example, let's change our patient's age. I was saying that at 35, half of the embryos are good, half of the embryos are bad. Now, my patient is 41, 42 years of age. That changes this ratio. And then we will then know that our patients will have 80% of these embryos being genetically abnormal, 2 of them being normal. Okay? At these ages, obviously, it does make sense to perform this test. Why? Because as I said before, neither John nor I nor anybody in the lab knows which of these embryos are the good ones and which ones are the bad ones. So John might choose this one, and that embryo is not going to implant. And if it does, it might miscarry. He might then, just by chance, choose this one. And same thing again. And we might take a few transfers to finally get to this good embryo. Now, what if, instead of doing that, we did PGT-A and selected these 2 good embryos? What would that do? When we transfer these embryos, we know these embryos are genetically or chromosomically normal, hence we will get our patients pregnant quicker. So time to pregnancy reduces. What else? Less chances of our patients to have miscarriages. Now let's be clear, this test does not reduce the miscarriage rate to 0. It just reduces substantially. So we will expose our patients to less risks of miscarriage. But this right here sounds reasonable and great in patients that have a very high ovarian reserve, patients with a high AMH, in which I know I'm going to form a lot of embryos to choose from. But the reality is the majority of our patients at these ages have a low ovarian reserve, and we will be able to form a lot less embryos. So I might only form 2 embryos in our patients. They might both be bad, or one might be good, one might be bad. So these techniques are generally mostly recommended when we're going to have embryos to select from. If I know from my patient's low ovarian reserve that we might only form 1, I'm not going to have an embryo to select from. So a lot of the benefits of PGT-A will be lost. And that is a conversation that the patient and the doctor need to have together. Because at the end, this is mainly an economical decision. Because these tests are very expensive. And I know that if I transfer an embryo that's bad, most of the times it's not going to implant. But if I do the test, I spend, I don't know, 3,000 euros or more just to know that this embryo was bad. At the end, the end product of this treatment will be the same, because there won't be a baby born. And this is why we need to be very clear. PGT-A does not increase pregnancy rates. It just increases the efficiency of our treatment. It reduces the miscarriage rates in the older cohort of patients, but it does not increase pregnancy rates. For this reason, if you go into the HFEA, which is the UK regulatory organization, it doesn't classify PGT-A as a valid technique. It puts it in red, which means this technique does not improve pregnancy rates, and it's true. There's countries like the Netherlands where this technique isn't even done. And until today, we have meetings that can last days on of discussions whether we should be doing this technique or not. And I believe that we should. I just believe that it should be done in the people that need it, that will get most benefit from it, and not just on any person based on age. I hope this was useful. John, would you like to add anything else?
No, you said exactly. The main way I see it is it's a fantastic selection tool, if that's the right word to use. For us in the lab, we can pick the most beautiful embryo. Everything's looking great. The time moves along within the day 1 to day 5. But as you said, we don't know what's going on internally in this embryo. So with PGT, that will help us narrow down these group of 8 or 6 embryos to that 1 or 2. Because sometimes it can be that patients can get a bit of a fright, especially when we call in the lab, that they could have 12, 10 embryos and they're doing well. But then there's only 4 that, or 2 to 4 that can be suitable to biopsy. and then that can drop again to how many are euploid or aneuploid, as I said. But as I said, it is a great selection tool.
A lot of studies coming out now on the use of AI and trying to predict this chromosomal abnormalities in these embryos. At the moment, sadly, we still don't have anything conclusive. But yeah, AI is advancing very quickly. repromed is engaging with this technology. So, so as soon as we have more news on this, I'll be happy to tell it to you guys. Have a lovely, lovely day. Thanks for listening, and I'll see you very soon. Thank you, John.
You're welcome. Bye.